things we can discuss over last around 40-45 minutes or so. So we start with the basic definition of anemia, the clinical approach, and understanding the basic CBC, and then we go on to discuss various case-based scenarios, be it nutritional, hemolytic, acquired, some uncommon cases, and treatment approaches across various age spectrum. Considering it only as a approach to anemia, I'll be focusing mainly on the benign hematology part or the classic hematology part, and just giving touches to the malignancy parts. So let's start. What is basically anemia? Anemia is actually a reduction in hemoglobin and RBC concentration. So basic function of RBC is to supply oxygen to various tissues in the body. And when this demand, tissue demand for oxygen is not met because of low hemoglobin RBC concentration, we call it anemia. So this is basically a functional inability. And this is very important line. Remember that this is not a disease, but a symptom of disease or an expression of an underlying disorder. So whenever we say that the patient is anemic, so anemia by per se is not a diagnosis. You need to understand that this is just a manifestation or a sign or symptom of a disease which is coming in this patient. So that disease could be nutritional, that could be anything else. And by default, there are cutoffs for anemia definitions. So males have a cutoff as per WHO of around 13 grams, females, uh, non-pregnant 12, pregnant females 11. Children's and infants, they have different cutoffs. For children up to 6 years of age, 11, and 6 to 14, 12 gram. Neonates have a very different cutoff. So newborns are born in a very polycythemic kind of a state, and normal hemoglobin can be as high as up to 15, 16 in neonates. So if we look at the prevalence of anemia, India lies in a very prevalent zone. So if we see the prevalence of anemia as per NFHS 2019 survey, it's around 53, which is considered among the severe zone. And this prevalence has kind of remained, same throughout. Although the prevalence of severe anemia has decreased from NFHS 4 to 5, but the prevalence of moderate and mild anemia has kind of remained constant, or in fact has slightly increased. So this is something which is an ongoing work for all of us. The population between NFS 4 and 5 has been, it's been a rise in almost like tens of crores. So the population rise, the denominator rises, but the number of patients who are still anemic, that is also rising. If we look at the approach to anemia, so approach to anemia starts with history and examination, and this will be our clinical approach always. We start with a very good history from the patient, do a focused examination in an OPD or in the ward, depending. The first and foremost investigation for the patients are complete blood count. So that gives you the, what the kind of anemia the patient is having, what kind of indices the patient has, whether other cell lines are involved or not. And in the basic workup of anemia, the importance of peripheral smear cannot be underemphasized. So this is one of the most important investigation, peripheral smear, when you think of a diagnosis of anemia and whenever you plan any kind of workup for anemia. And I'll aim to highlight this thing subsequently in my slides. So if we look at the important history points, the history points comes out as duration of anemia, fever, if any history of fever, bleeding, which invariably leads to anemia in a longer term, weight loss, joint pains, neurological symptoms, gallstones, pica. So specific symptoms are there which points out to different etiologies of anemia. Jaundice, gallstone, they go hand in hand with hemolytic anemia. History of neonatal jaundice, again a part of hemolytic anemia. For malignancy process, look for a mass or nodes, lymph nodes. These patients might be having fever and bleeding and weight loss as well. Look for a dietary history. Vegetarians are more prone for nutritional deficiency, especially for vitamin B12 as well as iron deficiency. History of blood transfusion for severity of anemia. Family history is again important. A lot more pediatricians and pathologists dealing with the young kids. So hemolytic anemia are important differential in such scenario. And hereditary hemolytic anemias, including thalassemias and other hemoglobinopathies. You will have a family history of pallor, jaundice, gallstone, even splenectomy. All such histories can be elicited. How do you look for anemia? You look for anemia in the conjunctiva, palm of the hands, tongue. Then there can be some specific signs like koilonychia, which can be seen in iron deficiency anemia. Signs of cheilitis, which are seen with the multivitamin deficiency and commonly exist iron deficiency. A bad tongue, knuckle hyperpigmentation are seen in megaloblastic anemias. Depending on the severity of anemia, the patient can have symptoms of fainting or dizziness. Then, if the anemia is prolonged and or with very low hemoglobin, or if there is acute anemia which develops over a matter of days or week, in such a scenario, the patient can develop signs of acute cardiac failure, or in a chronic anemia, signs of chronic CHF. Patient can have features of angina or even MI in such a scenario. Skin might be pale, may show yellowing if there is jaundice. Pallor might be appreciated in such scenarios. For hemolytic processes, spleen will be enlarged. Other important signs to elicit will include lymphadenopathy, cervical, axillary, and inguinal are the palpable nodes which we should check for in any anemic patients. Gamma hypertrophy and sternal tenderness in case of malignancy, especially leukemias. Nails, colonica, platinica, I have already told, knuckle hypertrophy, and other. Sensory motor neuro examination will be important in cases of patients who have chronic vitamin B12 deficiency, who may have signs of posterior column involvement. So this has been already highlighted that a routine, beyond the hemoglobin, TLC, DLC, and platelet, there are multiple other indices which come into the part. So in the form of RBC indices, platelet indices, differential counts, and nowadays many new counters they give even reticulocyte indices. This has already been highlighted in the last week talk, so I just quickly just go on to approach to anemia in such a scenario. So what you uh, the common indices which we as clinicians see in the OPD are MCV, RBC count, and RDW. So plus retic count. So on the Coulter report, these are these four parameters become very important for us. And the anemia approach start with MCV. So if MCV is low, we call it microcytic anemia. High MCV, macrocytic anemia. Classically, microcytic anemia uh, is seen with iron deficiency and thalassemias. Macrocytic anemia with marrow failure syndromes and megaloblastic anemia. And most of the other will have a normocytic kind of anemia. Next important thing is to look at the reticulocyte count. Reticulocyte count is a measure, if it's low, that is less than 75,000, we call them a hyperproliferative anemia. So it consists mostly of anemia in which the production of the RBC is decreased. This can be in the form of any disease process which is hampering the RBC production, bone marrow replacement by any processes, aplasia of any kind, or even nutritional deficiencies like iron, B12, folate, they all cause hypoproliferative anemia initially. But if the patient has been supplemented for them, what you get is a reticulocyte response in such scenarios. So, an absolute reticulocyte count of more than 1 lakh per microliter, that is a feature of hyperproliferative state in the bone marrow. Bone marrow has tremendous capacity to proliferate in such scenarios. So, it is said that the marrow can produce up to 6 times more RBC if a proper supplementation is being provided. So this hyperproliferative anemias will be in the form of all the hemolytic anemias and response to supplementation in case of nutritional deficiency. Then the causes in the pediatric and adult population will be slightly different. We expect that inherited hemoglobinopathies and inherited all other hemolytic anemias will be more commonly seen in pediatric patients. But nowadays, many of these patients are picked up in adulthood also, and as the survival of these disorders is improving, you will be seeing either as first time or as multiple as follow up in your adult clinics as well. There are certain disorders like PNH, MDS, and other things which are very commonly seen in which are more commonly seen in adult population. So this approach, this slide just highlights the if we combine retic count and MCV, which we commonly do in clinics. So both are low, then it's just the combined of various things. So you can have combination in which MCV and RDW will be either low, normal, or increase. Similarly with the retic count and high and low retic counts. Coming to the lab diagnosis, so these are the basic tests which you do for in the lab: hemoglobin, RBC morphology, and retic count. Our red cell indices are there in the report. If required, you do a bone marrow examination. Iron studies and B12 levels and red cell folate levels. They are commonly given as the initial workup depending on the community prevalence which you are dealing. So when we sit in a hematology clinic where the patients are kind of referred for many a times, the prevalence of nutritional anemia might not be that great. But if you sit in a community or in a pediatric or internal medicine OPD, in such a scenario, you will be seeing more of hemolytic anemia, more of nutritional anemias for that matter.
तो उन्होंने पहली ओपीडी कार्ड बना के रखा था तो वहाँ को
Most
इसको
of us
मैंने
are
कहा
familiar
मीटिंग
with
की
the
थी कुछ
various shapes
कुछ
of
टाइम से जानता
RBCs:
हूँ
normal,
तो उससे तो मैंने पहले
macrocyte,
ही पूछा था एक बार
target
जब
cells,
वो
nice,
वर्कशॉप में
stomatocyte,
फिर बोलने लगी तो लगी आप एक
thynocytes, fragmented
वो और
cells,
देंगे पहली
spherocytes.
मीटिंग का कुछ
All
था
these cells are kind of
एक बार
characteristic,
डिटेल मैंने कहा
and
पहले तो मैं जीत चुका हूँ
in a hemolytic
डिटेल
process, what
एंजॉय
we
करें
see is
कि मैं बहुत
reticulocytosis,
करा
presence of NRBCs, and
एक सेरम आई
polyphylacia in
थी
the
करा
peripheral blood.
सेरम आई जी तो मैं नॉर्मल
Uh,
एनटीटी जो
I
करा
think
देता हूँ
Manali or Sandeep will be
सारे
helping me
बच्चे
with the
देखते
poll.
हैं
So this is the first
बाकी
poll.
प्लास्टिन
You can
कैल्शियम
write
को
your
बताओ
answers
30
in the
ग्राम
chat
40
box.
ग्राम नहीं
All are features of hemolytic anemia except one, two, three, or five. Just write
मेरा
your
नींद
answers in
आती
the
है
chat
बहुत
box as
इसलिए को नहीं देखा
which is not a feature of
एक बार देखते
hemolytic
हो
anemia. Just write one of
अरे
the
ठीक है
answers.
कोई नहीं
Maybe Manali or Sandeep
साथ
or
साथ
anyone else can
तो
help
रैनी टीम का
collate the answers
रैनी
for
टीम
you.
से लूंगा मैं
Yes.
ये
Yes,
लॉग बोला
yes.
है उसने क्योंकि बोल रहा गेस्टाइटिस आप मैंने कहा गेस्टाइटिस तो मुझे रहता है कह रहा गेस्टाइटिस एक कॉज हो सकता है अंडरलाइन क्योंकि
So
जब तक अंडरलाइन
majority
कॉज
of
ट्रीट नहीं
people
होगा
are
और
answering
गेस्टाइटिस तो है ही
three,
मतलब
that is low
क्रोनिक भी है तो
lactate dehydrogenase levels.
Any other answers?
No, till now all are answering the same. There is one answer of
Low serum.
second option, low serum haptoglobin.
Okay. So what we understand that we are having a good audience which have uh, now very familiar with what kind of hemolytic anemias which the patient presented. So patients of hemolytic anemia will have a increased indirect hyperbilirubin. Haptoglobin is a protein in the blood which binds to free hemoglobin. So in all cases of hemolytic anemia, it will be low. If there is any evidence of intravascular hemolysis, so if there is evidence of intravascular hemolysis, in that case, haptoglobin will be almost constant. LDH is a marker of RBC turnover that will be raised in most of the cases of any case of hemolytic anemia, and especially if there is brisk intravascular hemolysis, which are kind of acute presentation. In those cases, LDH will be in hundreds to thousands. Other features of intravascular hemolysis include hemoglobinemia, hemoglobinuria, and hemosideриnuria. For the diagnosis of hemolytic anemias, you do specialized tests like osmotic fragility or EMA dye binding test, Coombs test, electrophoresis, estimation of SpA2 or sickling test, and G6PD test. So just remember, as a good pathologist and as a good clinician, you should be ordering all these tests not simultaneously, but depending on your peripheral smear finding. So if your patient is having a macrocytic anemia, there is no point ordering for HbA2 estimation or for HPLC test in such a scenario. Vis-a-vis, if your patient is having a sickling, sickle cells positive on the smear, you need not order for osmotic fragility at all. So be confident in your peripheral smear examination and then accordingly ask for specialist test to get the complete diagnosis. So what can be the cause of intrinsic RBC defects? For extravascular hemolysis, this could be intrinsic or extrinsic. So intrinsic blood defects like enzyme deficiency, hemoglobinopathies, and membrane defects, or extrinsic like all these causes. Intravascular hemolysis will be seen in
Excuse me, sir.
microangiopathies, transfusion
Sir, your PPT is not visible.
Yes.
reaction. Why so?
So it's
Shall I
your
just
Can
send
you
the
computer screen that is
experiments?
visible
stop
now.
sharing and reshare?
So you just reshare your screen.
Just a second. Is it visible now?
Yes.
Yeah,
Okay.
now it's visible.
So intravascular hemolysis, the causes can be microangiopathy, transfusion reactions, infections, and are causes like paroxysmal cold hemoglobinemia and paroxysmal nocturnal hemoglobinemia. These are relatively rare entities in routine practice, but in a hematology clinic, you will not be uncommonly seeing PNH cases. So let's come to basic approach. First, the approach in a newborn child. No, everything starts with a CBC, retic count, and replacement that will be uniform across the age group. If the retic count is low, it's a hypoplastic anemia. If the retic count is high in a newborn, you go for a Coombs test. If it's positive, likely causes includes ABO incompatibility or RH incompatibility. If Coombs is negative, MCV is low, look for alpha thalassemia syndromes. If MCV is high, then the other kinds of hemolytic processes they come into picture depending on your peripheral smear reports. So, depending on the peripheral smear report, there can be membrane disorders, metabolic disorders, or infections. Similarly, this we have already discussed in a child uh, or in an adult, depending on the retic count, hyperproliferative anemia will be there. Peripheral smear report is again very important, and go for specific testing after that only. If the specific test like the initial test of nutritional deficiency are normal, then proceed for a bone marrow if the smear reports are normal. Similarly, if the retic count is high, you assess for hemolytic anemia or responsive blood loss, review the peripheral smear and order for specific investigation accordingly. So what kind of findings can we see? So this smear highlights anisocytosis, poikilocytosis, pencil cells, likely iron deficiency anemia or thalassemia. This just shows some whole jolly bodies with the DNA fragments, likely megaloblastic anemia and post-clinic mutations. What is this? Basophilic stippling. Thalassemia, lead poisoning or megaloblastic anemia. Multiple target cells, findings seen in thalassemia, liver disease or hemoglobinopathies. Then multiple spherocytes, diagnosis likely hereditary spherocytosis or autoimmune hemolysis. In this, we can see bite cells and some Heinz bodies. Causes will be G6PD or oxidant hemolysis. These are characteristic sickle cells. There is no other differential. Then hypersegmented neutrophils, macrocytes seen in megaloblastic anemia. Acanthocytes, Burr cells, severe liver disease. Echinocytes are seen in severe kidney disease. If we go to the bone marrow examination, there can be various kind of pathologies which might be seen. So, if there is stem cell defect, there can be aplasia. When all the cell lines are decreased and marrow will be replaced with fat. If the disease is limited to erythroid series, you can have megaloblastic or sideroblastic or this erythropoietic anemias. There might be infiltration with tumors, leukemic cells, or other cells, myelodysplasia, myelofibrosis, or suppression because of either aplasia, drugs, irradiation, or chemotherapy. This is an important table. We understand the diagnosis of iron deficiency anemia is based on low hemoglobin, low MCV, and definitive diagnosis based on low serum ferritin, less than 30, and low transferrin saturation. Other tests like serum TFR levels, zinc protoporphyrin, hepcidin, they are all, more or less used in research setting. But these are the tests which should be used in your clinic for diagnosis of iron deficiency anemia. And it can invariably be easily differentiated from all the other causes which mimic iron deficiency state. So they can be functional iron deficiency or specifically iron deficiency anemia when both these things are low. Anemia of chronic disease when ferritin will be high. When both these things coexist in such a scenario, T saturation will be low, ferritin will be low, and other indices will also be low. What happens in anemia of chronic disease is that because of the underlying disease process, the macrophage and T lymphocyte they secrete various cytokines which suppress the bone marrow and kidneys by the decreasing erythropoietin and decreasing the erythropoiesis. Then the IL-6 which is secreted by these cells, it acts on the liver to increase the hepcidin production, which causes decrease in the iron absorption and release. All kind of chronic disorders like infections, malignancies, non-infection inflammation, they can all lead to anemia of chronic disease. We have a simpler approach to microcytic anemia then. Simple. You go for a retic count, ferritin, TIBC, and transferrin saturation. If the retic count is not elevated, check on these. Ferritin and decrease is classically iron deficiency anemia. You don't stop at the word of iron deficiency anemia. Look for the underlying cause, which is commonly you should look for malnutrition evidence or at least look for occult blood losses if there is no obvious history of blood loss. If ferritin and these things are normal, perform an HPLC. If the result is abnormal, this is likely a thalassemia or a hemoglobinopathy. If these are normal, go for a bone marrow aspirate. Look for sideroblast. And from the bone marrow, if these are not there, go for a toxic screen. If the retic count is elevated, you proceed accordingly. So it's important that when you have a diagnosed as a iron deficiency anemia, so per se iron deficiency anemia is not a complete diagnosis. You should look for the etiology of iron deficiency anemia. More commonly, what we see is iron deficiency anemia because of increased requirements like during growth or during pregnancy. But seeing a patient with chronic blood losses via digestive tract or other sources, this is not uncommon, especially in the elderly population. This is a very this is something which should be always be looked upon in a case of unexplained iron deficiency. Malabsorption syndrome like hyperchlorhydria, enteropathies like celiac disease, all these can be important etiologies in a suggestive history or suggestive setting. So if you have a patient who is malnourished, who is of short stature with chronic iron deficiency, look for celiac disease. This is one of the important entities to look for in to be excluded in such a scenario. Then really, with all these things suggestive, you can at times have a patient of a microcytic hypomic anemia when there is defect in the heme synthesis or ironization. There can be defects like DMT mutation, ferroportin, and other hereditary conditions which can very closely mimic iron deficiency anemia on the CBC and peripheral smear. What about approach to macrocytic anemia? So if the patient has a segmented neutrophil, hypersegmented neutrophils or macroerythrocytes, you test for B12 and folate deficiency, treat accordingly. If the B12 deficiency is there, look for the underlying cause, whether it is pernicious anemia, gastric restriction, or malnutrition. If there is no deficiency of either of them, look for dietary deficiency or other causes. For folic deficiency, most common cause is poor diet. Other causes can be drug induced or malabsorption again. If there is non-megaloblastic anemia, in such a scenario, look for retic count. This could be hemolytic process or disorders like alcoholism, liver disease, or hypoparathyroidism. This is basic approach to hemolytic anemia. So this is relatively easy. So whatever happens, proceed as per the blood smear report and order the investigation accordingly. So if there are cystocytes, you are looking for a microangiopathy kind of a thing, various causes of microangiopathic hemolytic anemia. Sickles are easy, bite cell G6PD and oxidant hemolysis, elliptocytes, spherocytes accordingly. Spherocyte approach is important. When there is spherocyte present, look for the family history and Coombs test. If Coombs test is negative, uh, go for osmotic fragility or EMI test for a diagnosis of spherocytosis. If Coombs test is positive, check on the drug history or the underlying etiology, especially of collagen vascular disorders in younger patients and uh, CLPDs, chronic lymphoproliferative disorders in elderly patients. So, some important cases. Okay. Yeah. So, this is about a 16-year-old female. History of pica, heavy menses in menarche. These are the RBC indices and hemoglobin value. Impression is that of microcytic hypochromic anemia. Diagnosis, iron deficiency anemia. Ferritin was low. The peripheral smear, I've already described the finding, the microcytic and hypochromic in red cells. Okay. This is again about a 70-year-old male. Almost a similar kind of a picture, but he is having a progressive weakness and tiredness for 6 months. RDW is high, WBC counts are normal, and platelets are high. The characteristic iron deficiency anemia peripheral smear. Platelet counts appear high, microcytic hypochromic indices. Ferritin is low, transferrin saturation is low. Important thing in such a scenario is looking for an blood loss kind of a thing. So in this case, 2 local blood was run, which was positive. Otherwise, look for chronic diarrhea, soft stature, and other clues in children. Look for bleeding in adults. And an appropriate step in most of these cases will be look to go for an upper or lower GI endoscopy if there is any evidence of blood loss in the patient from GI tract. Important is to find the etiology of iron deficiency anemia. Okay, uh, just a short case only. 14-year-old female, vegetarian by diet, fatigue, pallor, and shortness of breath on exertion. Some jaundice is there. Hemoglobin is low. The indices are shown to you. RBC and WBC count, platelet counts are here. Differential is here. What is your likely etiology in such a scenario? Just write in your chat boxes.
So majority of people are writing megaloblastic anemia.
Okay. Any other differentials?
What is the reticulocyte count? Someone is asking. Is
It's not mentioned. Sorry. Retic count is low in such a scenario.
no other differential activity.
So the
Liver
diagnosis
disorder.
like liver disorder could
One
be an etiology,
liver
right?
disorder and aplastic anemia. There are two more options.
Okay. So liver disorder could be an etiology in such a scenario. Aplesia, I won't completely agree. There is neutrophilic predominance. Platelet counts are kind of preserved. And there is marked macrocytosis. So what you have from this clinical picture and twos of, you know, adolescent girl, vegetarian diet, mild jaundice, mostly a preserved differential count. You are looking at a likely a nutritional disorder, megaloblastic anemia or macrocytic anemia because of nutritional deficiency caused by increased growth requirement is one of the stronger possibilities. Vis-a-vis, if we look at this smear, almost a similar kind of a smear. Here the platelet counts are normal. 60-year-old female, mixed diet, platelet counts are normal, slow WBC, MCV is high, and a normal differential. What could be the cause in this scenario? Just broadly, if you can answer, any specific things which comes to you might be seeing such a elderly female, mixed diet,
Um, we are telling MDS, myelodysplastic syndrome.
MDS. Yes. So that's good. Macrocytic anemia. For the first case, we had low B12 levels. Bilirubin was slightly high, mostly indirect. LDH is in thousands. Marrow, although not required, but if done will show megaloblastic changes. Okay. For the first case, there was reticulocytosis and resolution when you give B12 folic acid. So, this kind of response is pretty brisk. Reticulocytosis will be seen within first week of supplementation, and megaloblastic changes, they disappear from marrow within few hours only. So, normalization of counts, that will take some time, and normalization of hemoglobin may take even 6 to 8 weeks. For the second case, hemoglobin still remained low. It's important to rule out myelodysplastic syndrome in such a scenario. Whenever you're doing a marrow for myelodysplastic syndrome, don't forget to send cytogenetics and now myeloid mutation profile. The patient came out to be FAQ syndrome with myelodysplasia. Okay, next case. It's about a 10-year-old boy, lethargy and pallor. There is icterus, moderate splenomegaly 4 centimeters, severe anemia with spherocytes and high retic count on peripheral smear, slightly reduced peripheral smear, platelet count. Father also has splenomegaly and similar peripheral smear, but normal hemoglobin. No, uh, patient is serology is positive of parvovirus. He gradually improved his symptomatic therapy well, and when well, he's asymptomatic and maintains a hemoglobin 10 to 11. So these are the smears, multiple spherocytes. How do you diagnose spherocytosis? You do incubated osmotic fragility test, or nowadays you do go for a EMA type antigen test. Suppose this patient comes with pancytopenia. Same patient of hereditary spherocytosis comes with pancytopenia. What could be the possible etiologies in this scenario? Option A will be megaloblastic anemia crisis. Option B will be aplastic crisis. Option C could be a hemolytic crisis. So just choose any of these three options: megaloblastic, aplastic, or hemolytic crisis. If this patient of spherocytosis comes with pancytopenia.
Saying it's a plastic crisis, and one option is hemolytic crisis. One diagnosis.
So, both the things can be there depending if there's a underlying, infection which is precipitated kind of these things. So, parvovirus can cause even aplastic crisis in such a scenario. But a hemolytic or a megaloblastic crisis is also not uncommon, especially if the patients are not taking their folic acid and B12 supplementation. So, if the patient in such a scenario can present with low counts and megaloblastic anemia. In fact, megaloblastic anemia can be so pronounced that even the retic count and spherocyte might be masked by these by presence of macrocytes in such some cases. Okay, let's look at thalassemia. So thalassemias can present from totally benign non-transparent thalassemia trait to those requiring regular lifelong transfusion, that is transfusion dependent thalassemia, be it beta thalassemia major, severe heterozygous state like E beta, or alpha thalassemia. In between, there lies a spectrum of NDDTs who may require transfusion occasionally during pregnancy, surgery, or more frequent transfusion during poor growth or specific comorbidities. So next few cases will be about thalassemias. Okay, this should have been, this could be easier. So this is about a 26-year-old male. During his PSC for hernia surgery, he was found to have a hemoglobin of 10. RBC count is slightly high and severe microhypoindices, and RDW is just around 17. So what could be the differential in such a scenario? Is it iron deficiency anemia? Is it thalassemia major? Is it thalassemia trait or something else?
Thalassemia trait, most of them are, all of them are right now.
So that's a very good pick. So patient is otherwise normal, RBC count is high, and MCV is very low. So if you calculate, Menzer index roughly, it will come out to be pretty low. In such a scenario, thalassemia trait is your likely diagnosis. HbA2 is high and multiple microcytic hyperchromic crisis. How do you diagnose thalassemia? So thalassemia are diagnosed on the basis of hemoglobin HPLC or electrophoresis. Predominantly in a non-transfused patient, if you do HPLC for a thalassemia major child, you will get predominantly HbF. If there are prior history of transfusions, you should keep a gap of at least 6 weeks and preferably 3 months before checking for HPLC. Usually, that is not possible in most of the transfusion-dependent thalassemia patients because you are required to transfuse them every 3 to 4 weeks. In such a scenario, you should consider the patient for parental testing. For these, both the parents will be expectedly will be thalassemia trait, or if that is not possible, go for mutation testing in this scenario. In India, we have five common mutations for thalassemia: 619 deletion, codon 41, 42, codon 89, and IVS 1115 mutations. So these five mutations are responsible for more than 90% of the cases. So these targeted mutation testing can be done for such patients who are multiply transfused. Okay, next spectrum of case. So 24-year-old female, fever, decreased urine output, fourth day postpartum, antenatal and parental period were uneventful, blood pressure was normal, hemoglobin is low, MCV is slightly low, RBC count is fine, platelets are low. It's showing microhypotonia, high RDW, and low hemoglobin. What could be the possible etiologies in such a scenario? Is it iron deficiency anemia? Is it megaloblastic anemia? Is it aplastic anemia or some malignancy or something else?
Microangiopathic hemolytic anemia, one differential is there.
Any other differential?
No other answers now.
So, the history provided is characteristically of microangiopathic anemia or a HUS-DTP kind of history. So,
Yeah,
postpartum female with decreased urine output suggesting that kidney involvement is there, increased somnolence or decreased sensorium, likely meaning CNS involvement is there, fever is there. So the pentad of TTP is kind of getting
TTP.
fulfilled. So patient had normal ferritin, cystocytes in the peripheral smear, keeping a diagnosis of microangiopathy. Okay, so what is the possible etiology in such a scenario? Postpartum sepsis, DIC, TTP, HELP syndrome, or malignant hypertension? Likely, as you have answered, this is a microangiopathic hemolytic anemia, but out of four of these cases, which all can have a microangiopathy, which is the most common etiology which we are thinking of in such a scenario? You can write your answer in the chat box.
Answering postpartum sepsis and DIC, and majority thrombotic thrombocytopenic purpura. And few are also giving diagnosis as HELP syndrome.
Okay,
We have
so
three.
that's a good guesses. So HELP syndrome will usually have preeclampsia and high blood pressure. So that was not the case in this scenario. Postpartum DIC and TTP are your likely differential. Easier test to do in such a scenario is go for a population profile with PT APTT. The DIC score will be low in case of TTP and will be high if there is a postpartum sepsis. So for TTP diagnosis, you calculate the plasmic score, send for RMTS 13 levels and proceed accordingly. It's important and very important to urgently start plasmapheresis in such a scenario. So, further work check the hemodynamic stability of the patient. DAC profile is normal. In classical TTP, LDH will be very high, again in thousands. Mild renal deficiency, insufficiency will be there. Important to send the RMTS 13 level before you start plasmapheresis and start plex pending the report. So you send these RMTS 13 report, level. The report might take 2 to 7 days depending on the lab you are sending. But you don't wait for the report in such a scenario. In this high index of suspicion, you start with the patient on plex and steroids. Next, let's look at acquired hemolysis. This can be warm or cold antibody mediated or secondary to drugs, lymphoproliferative disorder, or collagen vascular disorders. Usually, the hemolysis is very severe. There is a fall of 4 to 5 grams or even more within a matter of days. Jaundice might be there. Mild to moderate splenomegaly might be there, and LDH very high. One of the important clues which you get is from your blood bank. When you send the patient for urgent RBC transfusion and a low hemoglobin, it is difficult to cross match a blood. Uh, what you get on this mirror is many spherocytes and fair number of reticulocytosis. So retic count can go up to almost 30 to 50%. Positive Coombs test is important to look for underlying etiology. Look for these etiologies. Okay. Next case. 1.5-year-old child with anemia, mild splenomegaly, dimorphic kind of blood picture, microcytic RBCs and microhypoimmune RBC and normal RBCs. If I say this is not a transfused patient, so consider in that regard, normal cells, hypocells, iron is increased, EIBC is normal, ferritin is normal to increase, and transferrin saturation is increased. So in such a scenario, one of the things which you should, this is definitely not an iron deficient kind of a state. In such a scenario, one of the differential which can come to your mind is a congenital sideroblastic anemia. You do a bone marrow, find sideroblast, diagnosis is kind of established. Nowadays, you can send the patient for genetic testing to look for the underlying disorder which might be contributing to it. Okay, so look for underlying causes in children, mostly inherited, although toxicity and other things like lead toxicity can cause it. For others, adults, look for drugs, look for toxicity, and look for MDS kind of a picture. In MDS, check for SF3B1 mutation and treat as per the cause. So, dyserythropoietic anemia can also be one of the etiologies for such a child. The patient may present with anemia and splenomegaly, and there are three types of dyserythropoietic anemia. Let's look at another case. So, this should be one of the last cases for me. Case elderly male presented with pallor and decreased activity, no bleeding or infections, 5 RBC transfusions. Pallor is there, no icterus, no bleeding, no lymphadenopathy, no organomegaly. Patient is also a known case of myasthenia gravis. So, what are your differential with such a presentation? Acute leukemia, myelodysplastic syndrome, PNH, or pure red cell aplasia? Do we have the
So,
answers?
yeah, the majority of them are telling it as pure red cell aplasia. Then few given diagnosis of myelodysplastic syndrome, and 2 to 3 people have given it as PNH. So
Okay.
majority is MDS. Second is
So majority is
myelodysplastic
MS.
syndrome. No, no, pure red cell aplasia. Sorry.
Okay. So both 2, 3, and 4 can be differentials in such a scenario. Based on this history and physical examination, you cannot rule out PNH, MDS, or pure red cell aplasia. One of the clues to pure red cell aplasia is history of another autoimmune disorder, which is myasthenia gravis in this case, which can be associated with thymoma and with pure red cell aplasia. So this is one of the clues which gives you a, you know, uh, uh, tilts you toward the diagnosis of PRCA. So if you look, the hemoglobin is low, WBC is normal, platelet is normal RBCs, retic count is very low, IRF is also very low, bone marrow was done, erythroid precursors are less than 5%. So diagnosing as red cell aplasia. So pure red cell aplasia diagnosis is based on decreased erythroid precursor in bone marrow and reticulocytopenia. Three types: congenital, acquired, or transient. Congenital, it's like a DBA kind of a presentation. Phenotypic is like this: high HbF and it's a ribosomopathy. In toddlers, you can see it post infections also, what we call the transient erythroblastopenia of childhood. It's usually a self-limited condition. In adults and in otherwise children also, you can have an acquired kind of a condition when this can be immune-mediated, drug-related, or in a aplastic crisis, or at times associated with other conditions, including large leukemia as well. So this is one of the important differentials, and depending on the age, you have to go for the treatment. So for DBA, treatment is transplant and steroids. For immune-mediated PRCA, you have to go for cyclosporine and steroids. This is usually a transient or a self-limiting state, so it resolves on its own. Okay, so that's my last slide. So important to remember that anemia is symptom, not a disease. Look for the primary cause of anemia. So whatever causes we discussed, we didn't stop anywhere at the diagnosis of anemia or diagnosing it as low hemoglobin or low RBC count. We have to go for the etiology of anemia. It's important to look for all the parameters in a CBC report. Good peripheral smear is very, very, very important. It helps you limit your investigation to targeted approaches and plan your workup accordingly. So if you're seeing lots of microcytic RBCs, lots of target cells, some NRBCs, there's no need to go for a marrow in such a scenario, uh, even if the patient is having, pancytopenia kind of a picture. So first rule out hemoglobinopathy in such a scenario. So important is peripheral smear is very, very important in such a scenario. One of the important thing which we should all remember, and as clinician, it is very important to emphasize is that the important diagnostic samples, be it for EMA, be it for OFT, be it for HPLC, all these samples are to be collected before you give a transfusion to the patient. For most cases of for anemia, plan a bone marrow if needed, depending on your peripheral smear finding, usually in consultation with a pathologist. Nowadays, mutation testing is very easily available. So, for hemolytic anemias or other difficult diagnosis, you can go for mutation testing if not required.